Welcome back, everyone. I hope you managed to get a cup of tea and a chocky bicky. I'm really excited to welcome our next speakers from IHACPA, Professor Kees van Gool, Executive Director of Pricing Analytics, and Dr. Sarah Neville, Director of Analytics. And they're here to launch IHACPA's new national benchmarking portal. I'm sure you'll have plenty of questions, so please don't forget to submit them through the Q&A function on the right of your screen. Professor Kees van Gool leads the team responsible for pricing and funding functions undertaken by IHACPA. He joined IHACPA earlier this year from the University of Technology, Sydney, where he was the Deputy Director at the Centre for Health Economics Research and Evaluation and Chief Investigator at the Centre for Research Excellence on Value-Based Payments in Cancer Care. He brings extensive experience in international, national and regional health policy research and quantitative skills in microeconomic modelling and linked data uses. So you can see why we were pretty excited about getting him on board. Dr. Sarah Neville is a statistician with a strong interest in health research and leadership. She's worked in the Australian health system for 8 years, seeing the price of hospital services in order to make hospital funding more transparent and equitable. Dr. Neville's passionate about the power of stats to inform evidence-based policy both in Australia and internationally, and she's also Australia's Harkness Fellow for Healthcare Policy and Practice for 22-23 and heading to the States in August. So thanks very much, Kees and Sarah.
Thanks very much for that introduction, James. I'm going to be sort of taking the reins today and talking you through the presentation, and Kees will jump in where necessary. So a little bit of an outline of today's presentation. We'll start with a bit of an introduction to IHACPA, just for those who aren't familiar with the organisation's work. And then we'll talk through the new national benchmarking portal with a bit of background on that development and the fact that we've been consulting about that for a number of years. I'll then talk through the main focus of the first tranche of dashboards that we'll be releasing soon, which is the cost per national weighted activity unit, or NWAU as we refer to it in this space. And then you're going to get the first look at the instructional video for the national benchmarking portal in just 10 or 15 minutes. So hold on to your seats, people. All right, if we go to the next slide, we're going to start with a bit of an introduction to IHACPA. All right, so what's IHACPA all about? Well, we were established under the National Health Reform Act back in 2011, with the major focus of the organisation to facilitate a nationally consistent system of activity-based funding. We specify the data specifications every year for nationally consistent data collections. We also publish the costing standards that spell out how the national hospital cost data collection is to be submitted each year by states and territories. We develop and set the classification systems that underpin the nationally consistent activity-based funding system. And then we also set the national efficient price every year. And some of the pillars that IHACPA has stood on from the very beginning are those of independence, consultation, and transparency. And these are the three pillars on which we have built the new national benchmarking portal. All right, so moving on to describe IHACPA's role in a little bit more of a visual sense. Australia being a federation of states and territories, and then we've got public hospitals that sit within these states and territories. The change in funding each year for public hospitals within Australia is a function of the change in price from year to year, but also the change in the volume and the mix of services delivered within those states and territories each year. So IHACPA is responsible for setting that national price each year, and it's the responsibility of states and territories and LHNs within those states and territories as system managers to determine the volume and type and mix of services each year. Taking that price and volume and turning it into funding is the job of another Commonwealth agency, the National Health Funding Body, and then that Commonwealth funding flows from the Commonwealth through to the local hospital network level. So just to reiterate, states and territories determine the volume and distribution of services, and IHACPA determines the price of those services every year. Now, where does the National Benchmarking Portal fit into this remit of IHACPA? So just to be clear, there is an existing National Benchmarking Portal, which has been hosted by New South Wales Health, along with their activity-based management portal. So they've hosted the existing National Benchmarking Portal for IHACPA since back in 2016, and access to that existing National Benchmarking Portal is currently controlled by state and territory health departments. The Pricing Authority, IHACPA's board, has had an objective to broaden access to cost and activity data for a number of years, and that was first formally canvassed in the pricing framework for Australian public hospital services for the 2021 financial year. We've been consulting on this issue since then with states and territories and the Commonwealth. And it was in mid-2021, so mid last year, that IHACPA actually began development of the new National Benchmarking Portal. And that's one that will provide broader access to hospital activity and cost data, and that portal will be available to the public. So very open with that access. So what is the new National Benchmarking Portal? Well, it's a website-based application that provides open access to insights from activity and cost data collected by IHACPA. It will allow users to compare cost and activity data from public hospitals around the country using the cost per national weighted activity unit metric, which I'll describe in detail in the next couple of slides. These cost per annum dashboards will be launched very soon. We are working on it. We're just sorting out some performance issues at the moment, and we will let all of our stakeholders know when we go live and when they can access insights from those dashboards. That's not the end of the story. We're also looking to develop dashboards on hospital-acquired complications, one of our key safety metrics, and avoidable hospital readmissions. And those dashboards will follow later in 2022, and we're looking at including risk-adjusted rates of HACs and avoidable hospital readmissions in those dashboards. Moving along to go into a little bit more detail about the cost per NWOW, or the National Weighted Activity Unit, and why we focused on that metric in our first set of dashboards. So what is the cost per NWOW, you may be thinking? Well, the cost per NWOW measures actual cost of delivering hospital services, but it adjusts that cost for case mix. The cost per NWOW has total cost on the numerator and our national weighted activity unit denominator. This cost per NWOW is influenced by the mix of services delivered and the length of stay, which is all encoded in the NWOW on the denominator, but it also takes into consideration the inherent cost profile of a hospital. The cost per NWOW is a great metric because it brings together changes in cost and activity into one measure, and it allows hospitals that provide very different services to be compared fairly. And I've got a bit of an illustrative example on the next couple of slides. So here we have hospital. It primarily provides acute and it's in an outer regional area. We then have hospital B, which it focuses on providing subacute and outpatient services.
and it's in an inner regional area.
If we were to think about comparing these hospitals in a relatively naive manner, we might think, okay, well, what's the average cost per separation or per presentation or per service event in the non-admitted setting? If we did that naively and we just looked at the average cost per separation, we're getting an unfair comparison between the cost of delivering a service at each of these hospitals. We're not comparing apples with apples here, which is not a great thing. It's not a fair comparison whatsoever. If we then look at the more nuanced measure of cost per NWOW that allows us to look at the mix and the complexity of services being delivered, fair comparison between these two hospitals, where the cost per NWOW is a lot more similar between these hospitals, and it's showing that Hospital A is operating more efficiently than Hospital B. It's a much fairer comparison than just looking at a cost per separation. We're now going to have a look at the instructional video for the National Benchmarking Portal, and this is the first time it's being seen, so please enjoy.
The National Benchmarking Portal is a web-based application that provides public access to insights from data collected by the Independent Hospital Pricing Authority. IHACPA is an independent agency that works in partnership with all Australian governments to improve health outcomes for all Australians. As part of the health reforms that led to IHACPA's establishment in 2011, we're responsible for setting a national efficient price for delivering public hospital services across Australia. The National Efficient Price has two key purposes: to help determine the level of Commonwealth Government funding for public hospital services and to provide a benchmark for the efficient cost of providing these services. This is done through the implementation of activity-based funding, which is a way of funding public hospitals for the number and mix of patients they treat. In order for activity-based funding to be effective, every episode of patient care needs to be counted. We do this by collecting hospital cost and activity data in consultation with states and territories across Australia every quarter. Cost data refers to the cost accrued during the delivery of an episode of patient care, categorised according to the different resources used during the episode. Activity data refers to the type and volume of the episodes of care. The National Benchmarking Portal presents insights from the combination of these cost and activity data sets. To understand the data in the portal, first you need to understand how the data is standardised to allow for fair comparisons. The insights presented in the portal use price weights and adjustments, irrespective of size, remoteness, or the type of service provided, to draw comparisons between hospitals, local hospital networks, and states and territories. The combination of these price weights and adjustments is known as a National Weighted Activity Unit, or NWOW, to compare activity across NWOW as a measure of hospital activity. NWOW accounts for the complexity and resource use of a hospital episode. An episode of care with a higher NWOW value is typically more complex and more costly to deliver than an episode with a lower NWOW value. Within the National Benchmarking Portal, there are three dashboards: Overview, Cost Detail, and NWOW Detail. The glossary tab defines common terminology used in these dashboards. Each dashboard contains indicators that compare data for the year selected to the previous year. Comparisons can then be drawn by filtering data by year, state, local hospital network, hospital, stream, and peer group. Once a filter has been selected, let's take the admitted acute stream as an example. The dashboards update accordingly. Let's further narrow our search to compare children's hospitals across the country by clicking on the Children's Peer Group. Once this selection has been applied, only the states and territories with specialised children's hospitals data are displayed. Further refine your search by clicking the bars in the graph, or using the lasso tool to draw a loop around your desired values. Other ways to filter data have been noted in the National Benchmarking Portal User Guide. which is available in the portal and on the IHACPA website. The grey bar below the dashboard headings will help you to keep track of your current selections. The cost detail and NWOW detail dashboards provide further insight into the cost per national weighted activity unit. Specifically, the cost detail dashboard displays the cost per NWOW by end class, cost buckets, and the average cost per NWOW over time. The NWOW detail dashboard highlights NWOW trends. You can use these dashboards to view visualizations for the current or previous year or over time. All graphs can be viewed in tabular form by clicking on the Show Table option. For further insight into each of the data representations, hover over the Information icon. Transparency is important, but privacy is too. Before data is uploaded to the National Benchmarking Portal, all of the patient information is de-identified. We do this by aggregating records that share a common variable, such as hospital or establishment, classification, stream, or month of separation. The National Benchmarking Portal also hides instances where the request returns statistics that are based on less than 30 records. It is important that users of the National Benchmarking Portal familiarise themselves with the user guide, as it contains detailed instructions on the navigation of the dashboards and proper interpretation of the data. The user guide can be accessed via the menu in the top right corner of the portal or on the IHACPA website. If you would like to learn more about the data collected by the Independent Hospital Pricing Authority, which underpins the pricing and funding of public hospital services in Australia, visit our website, ihpa.gov.au.
All right, thanks everyone. That concludes the formal presentation. So we'll hand back to James for any questions from the audience.
Excellent. Thank you very much, Keys and Sarah. So we do have a few questions. Looks like we've got the piqued people's interest. So Daniel Davies asks, what's the lowest level of granularity in the data?
Sure. So as it said sort of in the video, we have a number of variables that you can filter by and that are presented. So you can filter down, for example, in the admitted acute stream, you can filter down to, say, a particular hospital and down to a principal diagnosis, for example. And if that principal diagnosis and the combination of other filters that you have results in a sample of greater than 30 separations, you'll be able to view all of the statistics on that. So that's probably the lowest level of granularity we go to.
And there are a few options at that level below the hospital, right? So you've got principal diagnosis,
DRG, service-related group. Yeah, it depends on the service stream you're looking at.
Excellent. Okay, so we've got a couple of questions about access. So Lauren Robertson asks, even though the portal will be publicly available, is a login required?
No, so once we do go public, it'll just be like going to a regular website and a login will not be required.
Excellent. All right, thank you. And then I'm going to ask one that hasn't been voted up, but our good friend Brian Donovan in Ireland asks, will the dashboard be available to other countries?
Yes. Yeah, it'll be available globally. There's no restrictions depending on what country you're in. So you'll be able to view it from Ireland.
Excellent. Now, sorry, my questions are moving a bit. Matt Green asked a question that's close to my heart about private patients. So has cost per GWOW been considered to remove the impact on the metric by the private patient adjustment?
It hasn't been included in this tranche, but if that is something that users are after, it's certainly something that we could include later. There are there are certain pivots or filters that we would like to include in future releases. So we could have a toggle that where you could choose NWOW or GWOW. That's certainly something that we could consider. But in this lot, it's focusing on NWOW, where private patients, as you say, would have that lesser public patient equivalent, if you like.
Great. Excellent. Now, Penny Hendrickson's asked a really good question. How timely is the data? And what's the latest date range?
Very good question. So it's not time. It's currently, because cost per NWOW includes cost as the numerator, we've got the 3 most recently available years of national cost data. So at the moment, we've got 17, 18, 19, 19, 20, looking to incorporate 2021 once we've finalised that submission. Once we have dashboards that are that rely only on activity data, we could consider updating dashboards more regularly, so potentially every half year or every quarter, but that's still something that we have to discuss with states and territories and the Commonwealth around the quality of those data submissions. But at the moment, the most recent year of cost data and cost per NWOW is for 2019, 19-20 financial year.
Great, thank you. Now, the most upvoted question at the moment is from a guy called Samuel Webster. Is there an API or plans for one so that end users and researchers can work directly with the underlying data?
Very good question, Samuel Webster. We don't currently have API functionality. This was something that we considered for maybe tying in with ICD development, for example, and the WHO. It's a live issue. It's potentially something we can do, but it's not in there at the moment.
Great, thank you. Stephen Bornas asked to clarify what do we mean by public access?
I mean, I guess it's as public as you can be. There's no login required. It's literally like going to a regular website and you'll be able to view everything that you just saw in the instructional video.
So any member of the public with internet access can access the portal?
Correct. And it's also been developed using ClickSense, which allows viewing on tablets and phones as well. So you'll be able to go in via Safari and the visuals do sort of respond reasonably dynamically. In that sense, it's a bit more sophisticated than the old Click View.
Great. Now, Stephen T asks, does a hospital that's more efficient and have a better cost efficiency get any reward for the next costing exercise by IHACPA?
That's a very good question.
I might try and take that one. How's that?
A little bit beyond the portal. That's a policy.
So in terms of costing, no, but in terms of funding, more efficient hospitals in the system receive a higher price than their cost. So there is a inherent reward there. But having said that, that's only for the Commonwealth funding, and states and territories are able to adjust their funding however they wish. So generally, I think funding is very close to equal to cost. Now, Nubia Hernandez asks, can you export data to Excel?
You can. So when you look at each of those graphical representations, there's a little show table link where you can convert it into a table. And then next to that, there's a little export data function, and that allows you to download a little CSV.
Great. Now I've got 2 questions on Indigenous status. So I'll just ask, I think the the crux of those questions are: is Indigenous status available in the portal? Can we compare costs of Indigenous and non-Indigenous patients?
Very good question, and one that I also had in the last concurrent session about the benchmarking portal. We don't currently have Aboriginality available in the portal. So in developing the national benchmarking portal, it's always been sort of two things that are at odds. We want to provide public access to information and insights into the data, but we're also considering security and patient confidentiality is a huge thing that we always have at the front of our mind. And the fact is, variables like Aboriginality, postcode, another variable slipping my mind, are often very identifying for patients. So we don't have Indigenous status in the portal at the moment. It's potentially something that we could include, but it would need more investigation into how we ensure patient confidentiality. So not in there at the moment, potentially could consider in future tranches, particularly if we get feedback that that's something that users want.
But I think it also comes back to one of the earlier questions, that the unit of analysis is really around the hospital.
Yeah.
And that, of course, is the first aim of the portal.
For sure.
Excellent. All right. Well, thank you very much to Keys and Sarah. That was a great session. And thanks to everyone who put in questions. There was an awful lot there. Unfortunately, we didn't get through all of them, but we had lots of really good questions there. So please, on the way out of this session, provide your comments, your feedback on the survey, and I'll see you back very shortly for Martin Campbell from the NHS England session. Thank you very much.